All right. Okay. Good evening, friends. Welcome to yet another episode of the Gujarat Pediatricians WhatsApp group webinars. This is almost the 21st webinar in a row, except one or two times when we had dropped out, either because of the festival season or because of the election season. So, this is the last episode of the year, but not the least, because we have some massive faculty in the form of Dr. Vishwanathan and Dr. Neelam Mohan, our president-elect, who will take over January 1st. And we all will meet at Kolkata, hopefully, and see one another. We also had Dr. Shirish Patnagar as the third faculty, but for some unforeseen personal circumstances in his family, he is unable to join. So we will only have today Dr. Vishwanathan and Dr. Neelam Mohan. And we have a very young, energetic, but extremely popular and extremely able moderator in the form of Dr. Surabhi Dogra from Ahmedabad. So today we are going to discuss interesting cases in GI. So the faculty have taken some nice 4 or 6 cases, and it will be very interesting. But this is the second in the series of interesting cases. As you know, from last time we switched gear from topics to interesting cases. So we had interesting case in pulmonology last month, and we are having interesting case in GI this time. So we welcome Dr. Vishwanathan. We welcome Dr. Ramesh Bajania, the very able admin for the Gujarat WhatsApp groups, pediatrician WhatsApp groups, and he is like a rock solid support with all of us doing these webinars for last several decades, I would say. We also have a very young and energetic scientific coordinator, Dr. Krunal Shah from WAPI, who has joined since last 3 months and has taken sort of little burden off my shoulder by looking into nitty-gritties. So with that, we start. And Dr. Surbi, I would say that it's your prerogative as the moderator to introduce Dr. M. Viswanathan till the time Dr. Neelam joins, and we can start with the first case. So please introduce Dr. Viswanathan first.
Good evening, everyone. First of all, is the slide visible?
Yes, it's visible.
So, good evening, everyone. Joining us today as the first faculty is Dr. M.S. Viswanathan. He actually needs no introduction. He is a senior consultant, pediatric gastroenterologist and hepatologist, and a therapeutic endoscopist. Still, very few pediatric gastroenterologists can confidently call themselves as therapeutic endoscopists and pediatric liver transplant physicians at Apollo Children's Hospital in Chennai. And he's been a fellow of the Royal College of Pediatrics and Child Health in UK. And he's been an ISPEGAN invited fellow in pediatric liver transplant workshop, therapeutic endoscopy workshop, and pediatric IBD masterclass. And he has been invited as a speaker in various national and international conferences. And he has achieved an active pediatrician award by the IFP. And he is a distinguished clinical tutor by the Apollo Education Foundations, by Apollo Education and Research Foundations. So thank you, sir, for joining us today.
And I would also say that Dr. Vishwanathan is a great friend for both to me and Dr. Ramesh Bajania. Welcome, sir. You can unmute yourself, sir, and keep it unmuted now. Yeah.
Thank you.
Yeah, Surbi, go ahead with the case.
Thank you. And just I want to first of all like to say good evening, and I thank the convener Dr. Nitin Shahji and admin Dr. Ramesh Bajani, and the coordinator Dr. Kunal, and of course the moderator Dr. Surabhi, and of course my colleagues Dr. Neelam and Shirish. Thank you.
Thank you. Okay, let's start with the first case. Dr. Surabhi, all yours.
So the topic is very interesting: foreign body and corrosives. So just a brief introduction. Foreign body ingestion is most commonly seen in children below 6 years of age, and the most common foreign bodies which we acquire clinical practices are button battery, magnet, coin and other blunt objects, and sharp pointed objects such as nails and pins. So first we would like to solve a few of the questions, like what kind of x-ray should be done when a child with a foreign body ingestion comes to you?
Yes, thank you. And before I go to this question, because still coin remains one of the common foreign bodies, but of course the dangerous one is the button batteries or disc batteries, which we are seeing very commonly nowadays, especially the last decade or so. And I think we all know that because of this lot of toys available nowadays in our market, we have this kind of real problem. X-ray wise, going to the next slide. In the X-ray wise, basically, when a child presenting to an emergency department or to a pediatrician, of course, first thing is ABC. That's very important. And then you think about doing an X-ray. And before doing an X-ray, obviously you have to take an X-ray. History of the in history is very, very important to just to get an idea what's going on. Then you do an X-ray, because sometimes the history itself will tell you whether we're going to do an X-ray or not. But X-ray is anyhow is important. To do an X-ray, focus on the neck, the chest, do an AP and lateral view, and if possible, also include the dome of the diaphragm and a little bit of abdomen, particularly in an young child, if that will be possible. It may not be possible in older child, but definitely neck and chest and dome of the diaphragm. That's very important.
So many a times, maximum number of the times, child arrives late, and the relatives have given him a lot of bananas and milk for the easy removal and easy facilitation of foreign body. So is it recommended? Because even sometimes when the child comes from periphery, some of the physicians have advised, who are not pediatricians, like if you eat a banana, you take some milk, or it'll help in the easy passage and it'll not hurt the inner lining of the stomach or the esophagus.
Very relevant practical questions. Of course, pediatricians, when they refer, they can give that if they don't like you or me, because it actually is going to difficult, a difficult endoscopy. I remember a child, before the child had a foreign body injection history, but 12 hours ago, they did an X-ray, but they came to me, I have to do an X-ray before I proceed to the endoscopy. I did an X-ray, it's definitely the same place as it was in the previous X-ray. But when I went in, I couldn't see the foreign body at all. What I could see, however, was banana. So actually, I was peeling the banana. I could see the foreign body inside. So the thing is, nowadays, I think the idea is basically to remove it. If you're going to remove it, banana is really not going to create any sort of, usefulness. And more importantly, sometimes when you give a raw banana, actually, it's not actually a good laxative at all. It's the other way around. And moreover, in children, we have to give anesthesia. Ideally, 4 to 6 hours to solid, especially 6 hours solids and 4 hours to, milk, and 2 hours to clear liquids is very important for the anesthesia, to get safe anesthesia. So I think it may be a good idea not to give all those things if you're going to refer, and it's better, to avoid giving this one. So it makes life easy for the anesthetist and for the endoscopist.
So this is a complete no-no. And so will honey and sucralfate help?
I think to answer this question, one has to be very, very careful, because there are pediatricians who are listening to that. I just want them to start with a clear message saying that giving an honey or sucralfate should not delay your referral. That's the first point I want to say. Because and I had my colleagues saying from Chandigarh and Lucknow that they keep giving this one, they don't refer to that, so don't put the slide at all. That's what they keep saying to me. But anyway, I told it's very important for people to know this. If you think that you are going to refer this child, and if a child is stable airway, and if you're not suspecting any complications like bleeding or perforation, then you can give it. If you're going to, within the first 12 hours after injection, you can give that, provided that you are starting this referral process soon. You can give honey probably 10 ml, every 10 minutes or 15 minutes for a maximum of 6 doses, and sucralfate for a maximum of 3 doses, not more than that. Particularly in children more than 1 year of age, not less than 1 year, because still the risk of infant botulism is there. So you can give it, but important message is do not keep the child, refer the child on the way. They can do this, and make sure that their airway is safe, make sure that they don't have any complication, make sure they're stable, and that's very important thing.
So 3 points. First, make sure the child is stable, make sure the airway is secured, and third, even if you're giving honey or sucralfate, do not delay in reference. It should not delay in the referral of the child. And will laxatives help? Because many a times we have acquired some blunt foreign bodies or even the sharp foreign bodies, and parents are usually not too much to go for an endoscopy, and they ask this question that will laxatives help in the easy removal of these foreign
Yeah.
bodies?
It just depends upon the type of foreign body and where the patients or the parents are located. And more importantly, it's on individual basis. We are living in an era of medical legal era when you have to be extremely careful of what we do. The reason is, you always give, nowadays I keep telling people, you give suggestions in non-emergency situation. Let the parents make decision, or we will facilitate the decision-making process. Whereas obviously in emergency, a pediatrician have to make a decision for the best interest of the child. In a non-emergency situation, you have a discussion with them, let them make a decision, tell the pros and cons of what you are doing. Obviously, if there is a foreign body in the esophagus, definitely no. Or the sharp object or even a button bat in the stomach, I would definitely say no. if you are having a coin, it's an older child, and you think this might pass, there is a developmentally normal child, no other issues, healthy child, and I know the parents are sensible enough, then you could try and do that, particularly if there's a history of constipation. If there is no history of constipation, I don't think you need to definitely give a laxative. There's a history of constipation, the stable child, and if you think this child will not need an endoscopic removal intervention, then you could consider that. Otherwise, always get an opinion by the pediatric gastroenterologist, and then and take it forward from there.
So the most common foreign body ingestion is the button battery, as sir rightly mentioned. And so why button battery removal is an emergency?
See, I think button battery, or what we call disk battery, whatever it is, it has got a chemical in it. And also, when it goes into the our human body, the human tissue itself is acts as an electrical circuit, particularly the saliva. So I think the first thing will be actually the mechanical aspect, the pressure necrosis, the first thing. The second bit is the electrolysis aspect, and the third thing is actually the chemical aspect. And of course, the other thing important what you need to know that is sometimes there may be an issue of heavy metal poisoning, but that is not a major thing. The main modality of injury is the electrolysis and the chemical liquefactive necrosis. And when the problem is the button battery, particularly the esophagus, if it is an anterior erosion or anterior sort of a corrosive injury, you have an anterior to that, you have a trachea, or you could have in a bit of a major vessel there. Or if you have a bit of a posterior, you have spine there. Or particularly in the mid, at the aortic level, you have aorta there. So all these things, this erosion can erode into the vessel, the major vessel. There could be a significant fatal bleed or perforation. And also, a bit higher in the neck, it can also injure the thyroid artery. So all these things can really an issue, and that's the reason why we have to remove a button battery, particularly in the esophagus. Actually, the studies have reported, a significant injury within 2 hours after ingestion of button battery. So it's very important in any foreign body, particularly button battery or anything coin or sharp objects in the esophagus have to be referred immediately, and have to be preferably to be removed within 2 to 4 hours, particularly in the esophagus.
So as sir rightly mentioned, if anterior, there is a high risk of tracheoesophageal fistula, there is an injury to the vocal ward. In mid-esophagus, we could have a direct injury to the aorta, and posteriorly, we have spondylodiscitis. So sir, suppose we have got an X-ray done and the child, and we can distinguish grossly whether it is a coin or it is a button battery on the X-ray?
Yeah, thank you. And can you put to the full screen mode? Surabhi, is it a full screen mode? Is it? Okay.
It was on a full screen mode, sir.
Okay, but that's fine. Thank you. Okay, fine. Now I can just go back to, I missed this slide. I just slide on.
I'll put it.
Yeah, thank you. I think basically you have the disc or the halo. Basically, foreign body like a coin or the button battery is going to, if it is in the esophagus, it's going to be it is going to appear in the coronal view, the anterior posterior film. And if it is, you can see the disc, the double halo. If you can locate it, you can see it double halo, or in the lateral view, you can see the step pattern. And those are the ways you could, do this. Now, another important thing I tell, the referring pediatricians or parents is, not only for button battery, if there anything, they have a similar foreign body at home, to bring it actually, to get an idea the size of the foreign body. The reason is, I just try to, for example, there are some foreign bodies which are very, very unusual foreign bodies. I try to use my accessories outside before I go into the endoscopy, to get an idea which accessory is going to work for me. And that's another thing I always tell the pediatrician, if possible, if they have something similar to the foreign body, they are taken to bring it with them. So and so in short, in a button battery, you can just identify by the double halo or the step pattern in the lateral X-ray.
So this is a very nice practical point sir has given us, to get a similar foreign body, so we can priorly decide what kind of accessory, and we can kind of estimate what are we going to face inside once we enter with an endoscope.
The reason is what happened, the reason for that I'm saying that is, I had one child who had an unusually large, this AAA batteries. You won't believe this. They have taken this also. Sometimes you don't have adequate accessory. I need to get it from an adult site. So I just made sure I got it, and then I tried it outside. Then I made sure that this is going to hold. Then I went in. That is the reason we have to also prepare ourselves with the adequate access and the right accessory also. Yeah, thank you.
Very important. Nice point, sir. So when the button battery passes into the stomach or an intestine, so if the child is referred to us later because of the increased GI time, so is it necessary to remove it as soon as possible, whether it is gone into the stomach or in the intestine, or we can wait?
If it is in the intestine, yes, we can wait and watch. If it is in the stomach, I would say, again, you need to have an individual discussion, because the Spagan guidelines or the many articles says that if it is been there within, there has been a significant gastric mucosal erosions within 10 hours after ingestion of button battery. I have personally have seen within 6 hours a significant gastric erosions. So my point will be, have a discuss the family with the family. Are they going to keep looking for this button battery for the next 24 hours, 48 hours, 72 hours? Are they going to keep themselves off from their work? Are they going to be very anxious? I think we are now in an era where there is a safe pediatric anesthetists are available. You have got a good endoscopist. Why you have to wait rather than remove a potentially and a probable foreign body which could create a problem? I would rather suggest, if it is the stomach, to remove it. That's my personal, definitely strong opinion. Some people say that you can wait for 7 days. I would not wait if it's a button battery. I would rather get it removed if it has been there for 24 hours. I would not leave it long. I would rather have a discussion with the family saying that it's better to remove it. If they say yes, get on, remove that. If it is intestine, you have to leave it. You have to wait for it to come down. If there's any problem, even in the intestine, if there's any symptoms, then you have to intervene early.
Okay, sir. And one more point I would like to add: if even if the button battery is present in the stomach or the intestine, it does not rule out any damage to the esophageal mucosa. There still could be damage to the esophageal mucosa
Particularly if they're present late. Yes,
if
that's correct.
if
Correct.
they present it. Yes, sir. The complications, sir, we've already discussed
Yes, correct.
of the button battery ingestion. So moving forward, so we had this case of a child who had ingested a button battery and it was stuck in the esophagus. As sir had rightly explained, that it forms a circuit, the positive and the negative poles. It forms a circuit and there is a release of acids, liquefactive necrosis is seen. So post removal, this is the picture of liquefactive necrosis which is seen in the esophagus. So
Another
sometime,
important thing is, another important issue one needs to ask is, whether this child had a history of any previous surgeries, because the chance of getting impacted is high. And also always ask any history of previous corrosive injections. And all these things gives us an idea whether the risk of getting the foreign body retained is the risk is higher. Yeah, carry on. Yeah, thank you.
so another case of a Duracell battery ingestion. So this is less commonly seen, but still seen. So is it necessary to like, and you can see the food stuff also. He was also given a lot of bananas and for that to pass because they thought Duracell would not leak and pass forward. So do all the cells other than button batteries, the simple button batteries, require urgent removal?
But I think it depends upon the size of the battery also. If it is larger than 5 centimeter in length or more than 2 centimeter in diameter, and definitely I would say just get on, particularly the child is less than 6 years, it's better to remove it because it's not going to go away. And the reason is that two things is going to happen. You end up keeping repeating an X-ray, because the reason I'm saying this is, I recently had a child from Andaman Nicobar Islands. You won't believe this. This child has taken a coin. They kept taking on X-ray for last 8 weeks. The child came to me after 8 weeks. The coin has not moved from the place wherever it was seen, the first X-ray. What's the point of keep doing an X-ray when you are living in an era where there are adequate therapists are available, appropriate therapists are available? So what happened is, this is not a bigger coin. Actually, it's a smaller coin. It has passed to the pylorus, but it got stuck up in D1. I don't know why it got stuck up in D1. Just it was sitting there all along for 8 weeks. So what I'm saying is, foreign bodies, if it is there more than 48 hours, 72 hours, is very likely it's going to get across, particularly if there is something, a worrying foreign body. And especially if it is there more than 7 days, get them removed. Yeah.
So moving on, blunt objects. So why blunt foreign bodies need to be removed, sir?
I think it depends upon the size, actually. Definitely, for the esophagus, it has to be removed, whatever it is. because when it's esophagus, it's going to create problem. You're not going, the child is not going to eat for the symptomatic drooling of saliva, breathing difficulties, or unable to eat. You are not going to keep the child, no, okay, I will wait. No, it's blood from body. No, you have to remove that. If it is the stomach, or if it is size is better, definitely, as I mentioned, more than 5 centimeter length or more than 2 centimeter in diameter, it's better to remove. It's not going to come out, go through, particularly child less than 6 years of age. Otherwise, if it is really, if you want to wait, you can wait. Otherwise, it's better to remove that.
So as Sir rightly said, if the coin is stuck in the esophagus, but still if the child is asymptomatic, it does require removal because the diameter is more than 2 centimeters, it won't pass, and the age of the child is less than 6 years. If the coin has passed into the stomach, how long can we wait?
I think, as I mentioned earlier, the coin, if you're I think the newer coins are slightly lesser in diameter compared to the older coins. But having said that, most of the time the parents will not know exactly what sort of coin he has taken. So again, have a discussion. If the child is very well stable child, more than 6, 7 years, a very well grown child, parents are sensible, you can wait and watch for 3 or 4 or 5 days, maximum 7 days. If not, have a discussion. If they want to get it removed, remove it. But I'm not saying that you have to remove the child is got a coin in the stomach, but also make sure there is no other foreign bodies injection is there. Sometimes it will be surprising to know that I had a child who had a foreign button bud injection taken, and then they came, I took an X-ray, there's another button bud lower down the pelvis. So basically, these parents were basically having a toy shop. The child was playing the toy shop for the last 24 hours or 48 hours. Child had and 2 injection. So sometimes the X-ray will throw you some surprises also. But frequent X-rays, I'm not
And
a
how
big fan of.
frequently
No,
X-rays?
no, no, I'm not a big fan of frequent X-rays. I said told you earlier. I think if it is there, it is there. If you're going to watch in the stool, if it is not there, better wait for 3 or 4 days, get it removed rather than keep on taking X-rays. It's not going to allay the anxiety. You can do that, but
So another
that's an era of a decade ago, not necessarily now. Yeah, thank you.
Another foreign body which we commonly see is the magnet in the body. So is it urgent, or why is it urgent to remove a magnet?
Particularly if
And does the number of
yeah,
magnets ingested
if the
matter?
size is big, or if there is one or two more than one magnet, or if there is a magnet and another metallic object, it has to be removed because they can attract each other and that can result in a tissue necrosis and bleeding and perforation. Yeah.
Sir has answered the third question as well. If there are more than one magnets, they can cause pressure necrosis, tissue necrosis. They can also lead to fistula formation. So going ahead, sharp foreign bodies. As sir said, sharp foreign bodies require urgent removal. Symptoms are more common if they're stuck in the mid-esophagus, causing pain and dysphagia. So 100 positive predictive value on X-ray, metallic foreign bodies 100% seen, glass 3%, fish bones 26%, and wood is completely radiolucent. So ileocecal region is the most common site of perforations, but perforations are also reported in the esophagus, pylorus, angle of duodenum, and colon. So moving on, a 3-year-old girl ingested a metallic foreign body while playing. She was asymptomatic as per the parents. She was referred 6 hours after the ingestion. So this is the X-ray. So this was X-ray when she had after 1 to 2 hours after the ingestion of foreign body. And after 6 hours, she came to us, endoscopy was done, and the foreign body was found in D1. So it was lucky that it did not perforate, it did not cause any type of pain, drooling of saliva. So everyone may not be as lucky as this child. So what to do if the sharp object could not be retrieved on upper GI endoscopy, sir?
I think there are special equipments available. No, there's over the tube. We can use those kind of things, and then we can. There are options available, and also especially the sharp object has been in place for more than 12 hours. Always better to do a CT scan before you try and do that because that could be a risk of impaction or a perforation could have happened. Always do a CT. Always inform your surgeon and just keep them ready. And then sometimes what happens if you're not experienced enough, you can nothing wrong in taking what to say help from an adult endoscopist also. But it
And
has to
so
be done. It has to be done by you, but they can give you a hand. Yeah.
how long do we wait if it has passed beyond the if it is in the jejunum or in the ileum, how long do we wait for
I
the
think
sharp
again the issue is about whether the child is symptomatic or not symptomatic. That's the main thing is going to decide, and the size of the foreign body. If the child is asymptomatic, people say you can wait even for 7 days. But the sharp object, you need to be always be careful here. I think you need to consider about doing an X-ray here much bit more frequently rather than a blunt object. And then you definitely keep them informed about all the potential risk. Yeah.
and so should laxatives be given in
As I
the
told you, no, it's not needed if there's no history of constipation. I won't do that. Yeah.
and if on repeat x-rays, if it is found to be a colon, should we go ahead with the colonoscopy like we
If
give?
it, if it is if it is a shop that getting stuck there for longer period of, then you do that. Otherwise, if it's already gone to the colon, you can wait for some more days. Nothing wrong in that.
So longer means how long? 1 week, 2 weeks? I had a
No,
child where 2 weeks not passed, ultimately passed out.
no. If it is sharp object, I
No,
would
not sharp, round one.
round one. You can. So I think basically you can wait for 1 week. That's my thing. If
Okay.
people say you can wait, keep long, you can keep waiting long, but always have a discussion. Always
Yes,
discussion.
yes,
If they want to remove, let us remove it. Why you
yes,
want to
yes.
keep? I think the child, the parents have to sit at home to keep observing the stool.
Correct. So we welcome Dr. Nilam Mohan. She has just joined. As we expect, she's really must be very busy with all the work for the next year starting. So, Dr. Nilam, welcome.
Good evening, ma'am.
Yeah, continue. Should we continue?
Good evening, Neelam.
So moving on to our topic of corrosive ingestion. So corrosive ingestion, children constitute 80% of the burden and majority of them in the developing countries. Accidental ingestion is common in the younger children, and suicidal is more common in the older children and adolescents. So the severity of injury depends on whether it is an acid or an alkali which is ingested, the amount of acid or alkali ingested, and the site of exposure. So what are the common acids which are ingested are battery acids, industrial cleaning agents, toilet or metal cleaner, drain cleaner, pickling vinegar, vinegar spirits, and paint thinners. And the common alkalis which are ingested are grease or oil cleaner, drain cleaners, washing powder, paint removal, and household bleaches. So the topic of interesting discussion is whether acid or alkali, which is a better enemy. So quickly moving on, alkali is a high viscosity liquid. It has a longer contact time with the mucosa, and it causes liquefactive necrosis which can penetrate deeper into the tissue. Whereas on the other hand, acid has a lower viscosity, it runs faster. The physiological stasis is seen at the pylorus. It causes coagulative necrosis which leads to limited penetration. And so it is a pungent liquid as compared to alkali. So whenever the child takes it accidentally, he knows or she knows something is taken wrong, so he quickly throws it away, and so there is a limited intake of acid as compared to an alkali. So why immediate referral is required, sir, in the cases of acid or alkali?
Well, I think the important point is, we don't know the amount is taken, and more importantly, the oral manifestations does not tell you how severe the injury. Sometimes we have had a lot of children who nothing, we did not see any oral buccal mucosal injury, but definitely there was an injury in the esophagus and the stomach. So that's another thing is, the earlier referral is important to assess whether this any sort of injury has happened, also to grade it, because if there are grading there, grade 2B and more, the incidence of the possibility of the esophageal stricture is high, and that is a different sort of management. And more importantly, if ideally following corrosive ingestion, you do an assessment within 24 to 48 hours. If it is more than 40 to 72 hours, the risk of perforations goes higher. So it's better that we assess early to grade and also to prognosticate the what is it, development of stricture also. Yeah.
So when a child comes to us, should gastric lavage be given? Should vomiting be
I
induced
think
to us?
that is a very important question. People used to give acid for alkali and alkali for acid ingestion. I don't think that is needed because it's going to go into exothermic reaction. Vomiting again going to re-expose the esophagus again to the particular irritant. But so it's better not to be done. And if at all, you basically stabilize the ABC, probably cite a cannula, make sure airway is stable, and refer early. That's the only thing. Yeah. And you could probably start at proton pump inhibitors, nothing wrong in that, because that is absolutely fine. But otherwise, refer these children early. And try to ask the parents again to come with that whatever they think the child has taken, because we need to look at the constituent also. And if possible, contact an emergency poison center, because we are, as a gastroenterologist, we will be dealing with the gastric aspect, the esophageal aspect. We will not be dealing with the systemic side effects or toxicity. So please do address those things from your side, if there is something very important.
Will giving cold milk help? Because it's usually burning. Child
No.
usually complains of.
It will definitely not help the endoscopist. Again, it's going to, what is the limit, the visibility, and also it's not going to help the anesthetist.
So should a nasogastric tube be inserted once the child
Yeah.
arrives?
In corrosive, there is always a risk of, some sort of injury to have happened to the esophagus. So it's better not to insert NG tube blindly. After the assessment by the endoscopist, we will decide whether the child needs NG tube, particularly whether to keep it open or for enteral nutrition. And that's the main thing we will decide. And that we will be doing on endoscopic visualization.
And sir, what are the complications of a corrosive
As
ingestion?
I told you immediately, they depending upon the site of the maximum ingestion, it could be even the respiratory compromise could be there, or it could be a dysphagia, it could be a perforation, that could be GI bleed, or a little later they could have stricture with a significant amount of ingestion, significant perforation, they could have sepsis and peritonitis.
So when endoscopy cannot be done in case of a corrosive ingestion?
As I mentioned earlier, airway compromise or then a hyperpharyngeal injury. It may not be possible to do that. One has to stabilize the airway, and then after some time we have to do that. And so, but otherwise, usually, even if the child looks stable, there may be a possibility of getting endoscopy done to know exactly whether the significant injury has happened or not.
And when does the healing begin once the
After
corrosive?
after after 2 or 3 weeks.
And what is the when is the highest risk for a spontaneous perforation
Yeah,
after?
within the first few days, 3 to 4 5 days. The nutrition,
And
we try always go for enteral nutrition. We do not advise parenteral nutrition. Whatever the disease nowadays, we always try to use the gut whenever it is possible. So I think even if you suspect a stricture, we may try to push an NG tube, and we'll try to what to say, give the nutrition to that. Or if we are going to suspect a very delayed recovery for this child, we can also go ahead with the percutaneous endoscopic gastrostomy, particularly if there's a esophageal stricture. Yeah, we just discussed that. Yeah, carry on.
so this is the Zargar classification as we classify the esophageal lesions and the stomach lesions. So on corrosive injury, so
Yeah.
normal
Yeah,
mucosa
just
grade
don't
1
just the grade 2 and grade 2B and above is severe
above
injury. That's it. Yeah.
severe injury. So just a case, a 7-year-old was referred with accidental ingestion. Unfortunately, it was a mixture of acid and drain cleaner. Acid and alkali was mixed together. On arrival, he was vitally stable, conscious, alert, but drooling of saliva. He was kept NBM. X-ray was normal. Maintenance fluid, antibiotics was started. Endoscopy was done within 24 hours of ingestion, and nasojejunal tube was inserted. So this is the endoscopic picture of the esophagus. As you can see, grade 2A burns. The body of the stomach where the stasis happened, so you can see grade around 3B necrosis is seen. This is the fundus. Fundus is also 2A to 2B, and D1 has also been injured. So we couldn't go, nasogastric tube would not help, so we went ahead with a nasojejunal tube. And sometimes what we see, if there is a lot of damage to the oral mucosa, we think there is not much damage inside, but here there was damage beginning from the oral buccal mucosa right till the D1. So fortunately, we kept NG tube was inserted. As sir rightly point out, we started maintaining nutrition through the NG tube. The child healed well. Repeat endoscopy was done after 3 to 4 weeks. Healing was documented, and nasojejunal tube was removed. Thank you.
So one important thing I want to mention in corrosives is, I
Yes.
just want to know whether you come across this paraquat poisoning is a herbicide.
No.
It's
Yes, sir.
common in South India. The reason
No.
I'm just particularly mentioning about this paraquat is, this is one which is available in some forms. It can have a end organ damage, particularly lungs, kidneys severely. Of course, it's a corrosive. It can also damage the GIT. The reason for me mentioning is, if you identify this the ingestion, you can do this urine diethionate test, which you can do the bedside. You can recognize that. And if you recognize early, if there's a need for hemodialysis, or if you start it early, you will be able to save these children. Otherwise, they end up with acute renal failure, or in the long term, they could have lung fibrosis also. That's I just want to mention about that. And of course, anticipatory guidance is what very much important for all the foreign bodies or all the corrosive injections. I have seen parents, foolishly keeping their corrosives in the very nicely colored Fanta bottle, Sprite bottle, and particularly in summer, the children go and drink it from the fridge, as they're very thirsty. And that's one thing we have to keep on advising to the parents about the anticipatory guidance. Thank you.
Thank you, sir. Thank you so much for the informative session. So now we should begin with the
Yeah. Dr. Nilam is there, so you can take the second case with her. Madam, you can unmute and put your video on.
Yeah,
Yeah, that's
yeah.
right. There she is.
Good evening, boss.
Welcome, Nilam ma'am.
Thank you, thank you. I have a moving office in my car.
Actually. So what
No,
you get? Okay, fine. It's okay, no problem. If your bandwidth goes down, put off the video. I mean, we'll tell you. Yeah. But now
No,
you
I'm
continue.
fine.
Now it's okay. Chalo, Surbi, continue. First
Yes, sir.
introduce and then continue with the second case.
Yes, sir. So
I
screen
mean,
is
she doesn't need introduction. She's a, she's a.
So, Madam is our President-elect 2026, and she's also a BC Roy awardee. President, she's also been a ex-president of ISPAGAN and ex-president of CAPGAN. So, quickly moving ahead, Madam.
Yes.
So, the topic we are discussing today is pediatric acute liver failure. So, beginning with the case, a 6-year-old boy came with complaint of low-grade fever since 3 days, generalized weakness in 3 days, yellowish discoloration of eyes. Since a day and loss of appetite since a day. On arrival, temperature was 100 degrees Fahrenheit and vitally stable. Icterus was present. Liver was 3 centimeters below the costal margin, soft rounded margins, smooth surface, left lobe and spleen not palpable. And there was no rash, petechiae, lymphadenopathy, loss of consciousness, no itching, no abdominal pain or joint pain. So on day one,
A little slow because I've not read any message or any mail, so I'm going to read it for the first time. I've not seen the message mail that you had sent. Sorry.
no,
So now I understand a 6-year-old boy, typically fever 3 days, weakness, jaundice 1 day. So it starts 2 days later, loss of appetite, no pain, joint pain, itching, and vitally stable. Ictus, liver 3 centimeters, left lobe is not palpable. Excellent. So for the benefit of the others who are listening, the way she's given the history, she's made it very clear to me from this history that whatever has happened is sudden in onset. It looks like an acute, and also that she has given me history of this thing, liver seems to be soft and left side is not palpable. She's just trying to make me understand it not like a chronic liver disease, a typical. So this is what I understand from this. And since there is starting with fever and loss of appetite, it is taking me towards a viral cause from this that I should be looking. Wonder why she wanted to talk about rash petechiae? Basically, like, maybe like a dengue or strep typhus. So she wants me to get an understanding. Then she's trying to tell me no loss of consciousness, basically complications she wanting to hint at. And that's what I want to understand. Abdominal pain could be due to ascites or due to the disease. Joint pains not typically, but yes, again, viral if it is there. That's what I understand from the history. Yes, please. Next.
So on day one, CBC was within normal limits. HIV IgM came positive. Rest of the viral markers were negative. SGPT was 260, SGOT 300, total bilirubin of 5.5, direct fraction 4.5, and albumin was 4.2.
So there is one thing from this that I would like to tell the audience is, one, she gave me an history that the viral serology was positive, but something odd in this slide, if I don't know, are we allowed to ask the audience to put it in the chat box? There are two odd things in this picture, and One is if it is viral hepatitis, usually you should have SGPT more. She's trying to tell me OT is 300, so I'm a little alert. But she's also trying to tell me albumin is 4.2. So it thinks it's not chronic, it has to be acute that is going. But besides this CBC LFT, is she going to give me more information? Yes, over to you.
So on day two of admission, the child spiked fever of 101. On admission, it was 100.
So one thing you didn't tell me is what was the INR or maybe a renal function INR we don't have. Would you
We
like
don't
to?
have, ma'am, we don't have,
So this is outside history. Okay, fair enough.
yes,
We
ma'am.
don't have that. So that is probably one message I would like to give you all. If going back to that slide, what was the bilirubin?
5.5.
Okay. And enzymes were not very high. So you want to know the trend. You want to know where this is going to move. So right now, I don't know whether this is a mild, whether this is going to get into anything. We will see. Let us see what she wants to take me to. And now she says I admitted and fluid antibiotic. That was also not needed. Waverley would have doubted if you would have given antibiotic there. Okay. One more from this. I can see one mistake is valproate. Always one key message to remember for all pediatricians. Any patient with liver dysfunction, even if you think it is corrupt, then whatever you're thinking, whether it is viral or not, I would not like to give valproate. Next.
So day two of admission, he had a fever, a spike of 101 degree Fahrenheit. He had a episode of tonic convulsion, lasted for around a minute, settled on midazolam spray, but he was loaded with injection valproate. Gradually, they noticed that the jaundice increased, the irritability increased. The child was
How
appeared a
many
little
days?
confused, but
This
sorry,
is
ma'am.
at the same time, the next day or a day or what?
Day two of admission, the next day.
Oh,
So day two, he had a tonic convulsion, and then he developed the jaundice increased as the day passed. Irritability increased. He was confused, but still he was able to tell his name, recognize his parents. So he was diagnosed to have grade 1 hepatic encephalopathy. So in the evening, the LFTs were done, and which were increased as compared to the previous. SGPT of 600, SGOT 567, total bilirubin of 6.5, and direct of 5, and ammonia of 70. So enzymes took a jump over here.
now, in this, a little again, not future. Initially, if it is valproate, and I want to put on a so A, there was already hepatitis A positive. B, it was a mistake of the doctor to have given valproate because we all know that valproate, especially high risk is patients already with liver, even those patients who are on a valproate, they need to monitor liver, and especially young children, they can have issues with fatty acid, mitochondrial, these disorders. So they are a high risk, and especially those who have developmental issues, they're at high risk. I wouldn't want to get. So now on the right side, this is not fitting my jigsaw. If I think about a drug, now in fact the PT is more, so it looks more of a viral hepatitis only, and ammonia has risen. So that means I'm getting into complications. This is a bad omen that the ammonia is written. And now I would insist that we need to be having an iron.
So on day three, the child developed some abdominal distension. He developed pedal edema. The sensorium did not deteriorate. It was the same. He became afebrile, and a reference was given to the pediatric gastroenterologist. And then we did an LFT in which the SGOT and SGPT were SGPT SGOT was 700 and 590. Total bilirubin of 7.2, direct of 6.6. So, ALP 350, GGT 150, total protein of 5, albumin is 2.5, it is reduced, PT 13, INR of 2.5, ammonia 65, and sodium and potassium were in the normal limits.
Okay. Two, three messages I would like to give the audience here. Number one, that are these real cases, Surabhi, or
Yes.
a little con?
No, ma'am.
You are here. So, two messages I want to give, that there is no doubt this patient is a liver failure. How did I say that? Your INR is gone more than 2.5, and the definition is that anything which is above 2 is liver failure, or more than 1.5 is encephalopathy. So, even if she has not told me about sensorium. Second thing, normally a pediatrician and all, we worry how albumin is supposed to be a long term. I mean, 3 weeks is the half life. How can you get in a day? So, but we've often seen this happening, not necessarily malnourished, but we often see that there could be a leak, like a third space leaking, even with hepatitis A, not only with dengue, even with hepatitis A, we often see that the albumin can go low with ascites. But to me, this is looking a little odd. Somebody who was 4.2 coming to 2.5 in 2 days, something is looking not appropriate. But as I said, that you can have even in hepatitis A such a picture. But having moderate ascites makes me worry. Was the inside liver appropriate or not? Why did it decompensate? Why did it become moderate? It should usually be minimal ascites, which is more common seen, and moderate would be only when there was an underlying liver disease, or and the patient was malnourished. So something is a little not, but yes, it can happen, because the series that had come from PGI Chandigarh, they had said, and even SGPH series, they did talk about ascites even in Hep A. Yes, madam. So now the doctor was smart. He realized that it was a goof up. So Volpate was stopped and levetiracetam was started. And that is a good thing to give. And that's a key message, that choose levetiracetam as the first line of drug whenever there is a viral, whenever there is a liver injury. Is there any role of rifaximin? There is data in adults much, but not much in children. But having said that, we often do start rifaximin and lactulose, especially we are worried, when the liver is not metabolizing and ammonia is increasing. You want the stools to be loose and you want to continue. If I was in this, I usually like to do a D6 PD, because in North India we have 2.5% deficiency. So before jumping to vitamin K, I always like to do a D6 PD in North India. So that was the key messages. And here she says just increase eco texture. So right now she doesn't say, I mean, is it heterogeneous? Is it homo? So if she would have said hetero, it is more in favor of some underlying. If she says increased eco, it could be just edema there. And liver span is not very badly increased for that 10 years, usually 8 to 10. So, we are around there. I would have thought it should have been more, but anyway. And spleen is normal. So, once again, there is no evidence of an underlying liver disease. Over to you.
So,
So, another key message with that INR, would you like to give FFP?
no, ma'am.
Right. And why?
So we do not INR. So with the FFP, there is also a risk of transfusion related liver injury. And FFP, the main indications are if there is an active bleed or if we have a procedure planned. Only then we do give
So
an
that
FFP.
is the message for the pediatrician. Gone are the days when I would say that the pediatricians before preferring, even with an INR 2.5, they would be apprehensive, start with FFP, 3 FFP, 4 FFP, rather than can overload and lead to lung injury if you give too much of FFP also. And only if you're planning a central line, some procedure that you would give, or there was evidence of bleeding, which should not. occur at an INR of 2.5, you would need it much higher to have a bleed. Or if there was an associated dengue with very low platelets, then there would have been a bleed. Then again, you need to be smart and see was it just a coagulopathy and not just pump in FFP. Well said. Next.
So can I interrupt just one question, Dr. Neelam? You mentioned the role of G6PD because you are in North where Punjabis and these will have high G6PD deficiency. And suppose such a child where the child is really bleeding and it could be because of vitamin K deficiency. Is it that you can give instead of Caplin the Canadion, which is vitamin K1? And
Yeah,
also look at the quantitative G6PD. If it's not very low, you can still take a chance and give. Always you can transfer if the child goes into trouble. I mean, this is what we do
very,
in
very
hemat.
well said. To be honest, I have, it is the reason of doing that is not that you're not going to give. Number one, vitamin K is a little hyped up when it comes to acute liver failure. Now, vitamin K is more beneficial, especially with cholestatic liver disease, chronic liver disease. In my 30 years, I've hardly seen that somebody's INR is bad in an acute liver failure of a 3 days history, and I give vitamin K and, shakalaka boom boom, the child will get okay, won't. So the message I wanted to give pediatricians is they have a habit of writing vitamin K 3 days. So do you really need it? Need to see. But yes, if you think that you want to give and see, then you can give a small dose as highlighted by Nitin. I have given vitamin K, and we've got patients who wear GCPD and add vitamin K. So it doesn't, I mean, all these are little hyped up. You have to work case to case and see. But a blanket 3 days or 5 days of 10 mg of vitamin K in an acute liver failure with a 3 days history, I doubt how much it's going to help.
I completely agree. I mean, I would really fire residents if they've written vitamin K for 3 days for any illness. There's nothing like 3 days. You just give one day, you may have to repeat it every 2 to 3 weeks in case there is complete lack of absorption.
But
But you
this is
don't
the
keep on
way
giving day by day.
residents are taught, and they come when they come for my fellowships everywhere in the country.
Yeah,
That's what I see. So that's why I
yeah.
wanted to emphasize FFP, because they give 3-4 units before they come to me, and they give like loads of vitamin K. And sometimes when they are hemolysis, I'm into more problem because they get up into AKI, renal failure, hemolysis, and more than the liver. Now I'm working on the kidney and
Yes.
dialysis to save the kidney.
Yeah, and the last comment, of course, not related to liver failure, but newborns are given vitamin K and they are given at birth where the G6PD is still not available. It is safer to give Canadion rather than to give Caplin, which is not K1. Canadion is K1, that's more safe.
Right, very well
Go ahead,
said.
Surbi. Go ahead, Surbi. Uh, Dr.
So
Jalil
the
wanted to make
history
a
was
comment,
again
Dr.
reviewed.
Jalil? I saw hand raised by Jalil. No.
Sir, this is regarding the vitamin K, sir. What
Yes,
the
yes.
regular vitamin K parental is not pure. It has got
Correct.
some impurity also. We have a vitamin K anaphylaxis in the ICU.
Oh,
So you should be very careful in giving vitamin K, especially the parental vitamin K. We had
correct.
one or two occasions of anaphylaxis and we rescued the child. That's
Oh,
my
this is
comment.
news to me. I've never, good you said, I've never seen, but we should be careful.
No,
All
Madam,
right,
vitamin
this
Surbi.
vitamin K is an impure materials, not a
Hmm.
pure materials.
All right, Surbi, continue with the case.
sometimes guideline also suggests that instead of giving an IV vitamin K, we can also give a subcutaneous or an IM vitamin K.
Never IV vitamin K. Never. Even in the baby is in the end stage, don't go for vitamin K IV.
Correct.
So we reviewed the history again. The child had a history of febrile seizures, which was not taken, and we also took a history of if there was any alternative medication given, it was negative. There was no similar history of jaundice in the sibling or family. There was no history of sibling death or recurrent abortions in the mother, and there was no history of recent travels.
Correct.
So, looking at the clinical picture, of course, serial LFTs were done on the alternate day. SGOT, SGPT gradually started declining. Bilirubin was a little stagnant, but it was still not rising above 8. ALP, GGT were fine. Albumin slowly started to improving, though it dropped down to 2, but it gradually recovered on day 7 of admission. PT-INR also improved and electrolytes were in the normal limits. But still, looking at the deranged electrolytes, we went ahead with the other causes which can be seen in this age group. Wilson's disease, we did a serum celluloplasmin of 35, and autoimmune workup was done, which was negative. So the child was stable. There was no further deterioration. Grade 1 encephalopathy did not proceed further. Same treatment was continued. Neurology reference was taken and levetiracetam was continued. Again, serial LFT shows gradual decline in SGPT-OT, bilirubin reduced, INR improved to 1.5. So the diagnosis was acute liver failure secondary to hepatitis A, and which was the clinical condition improved. The child was discharged, and on follow-up, the PT-INR and the LFT were in the normal limits. So what went wrong? If you go to see.
So one, I think, as I was saying that, Walpret was not a healthy thing to give. And now that you're saying there was, usually when there is a seizure, I think what you gave me the history is there was fever sister at that time. The patient was, not even encephalopathic and not even coagulopathic much. They didn't do even a coagulopathy. So one key message I would give is stay away from valproate, tegretol, all these things, and choose levetiracetam in today's era, which is liver safe.
So as
So
Madam,
there is something in the chat which is saying Dr. Moni wants to know something about hepatic drip.
Use of hepatic drip, what is that?
Moni, you can come on. You can unmute yourself. Dr. Moni. She's still there? No. All right, till the time she comes, I think I also wanted to bring to notice that during COVID time, people were taking a lot of Giloy as an Ayurvedic supplement, saying it's an immune booster. And there was a case report of Giloy induced acute hepatic failure.
yes,
A patient died, needed transplant, and all sorts of things. So when you ask that alternative drugs or alternative treatment, I think that's an important thing, because we also seen in children not hepatic failure needing transplant, but definitely a chronic liver disease like picture, and you then find out some drugs are being given from spurious sources, and then you withdraw the drug, and within few months the child comes back to normal.
And just to add to that, Dr. Nitin, basically
Yeah.
when when there is a history of this complementary medicine intake, and then sometimes the antibodies also confuse us. Actually, the child may not have an autoimmune liver disease, but we find some bizarre antibodies. And
Oh.
when we evaluate all these things, then and the liver biopsy says, oh, could there be some eosinophilia? Could there be the drug history? Then the histopathologist asked me. So always is very important. We ask for complementary or alternative medicine intake. Not only that, we also have to ask about the overdose of allopathic medicines, particularly paracetamol.
Correct.
I agree.
So, can I make a comment, Nitin ji, sir?
Yeah, Jari, this
Sir,
please.
sir, this is hepatitis A going in for a devastating acute liver failure is rare. It can occur also. I just wanted to know the underlying disease, pre-existing or underlying disease can be easily picked up by GCT. I want madam to comment on the GCT, the value of GCT. Many labs, they don't provide that information. If this
Okay, so
GCT will pick up the
that-
underlying disease, madam.
Yeah, so two things. That's what I always say. That over the years you learn, you teach common things that in evidence and liver was, just 3 centimeters. There was no spleen, and the flow was not CLD size. Albumin to start with was 4. So it looked less likely. But the only thing which I said to you was odd was, she, that's why I asked, did you, in real case, if you remember, was 4.2 getting with such low in 48 to 60 hours with an albumin of 5, usually unless, but it can happen. That's why I said it can happen in there could be a third space leak even with Hep A, and it has been reported virus is virus. But having an underlying autoimmune liver disease or an underlying Wilson disease, which gets precipitated, these all have to be thought about in a patient. But in this patient, was it just Hepe or Hepe and Valproate? Too early to say. But anyway, as I said, that the child was the only risk factor was there was a liver injury, but that child was not developmentally abnormal, young. But usually, young age group where we think more of metabolic, mitochondrial, fatty acid oxidation, they're usually 2, 3 years old. But having said that, people have reported mitochondrial presenting at any age, even in teens and later on also. So these are the patients that you're worried that there was an underlying liver disease. But that's why I said when she was talking about ultrasound, you heard me, and I said she didn't say anything like a steatotic liver, which again you would have seen in an underlying liver disease. So to me, this looks like a Hep A blanket which happened and the child improved. And are we justified in doing so many autoimmune liver markers? I find it a waste of money. I would have just done an immunoglobulin G level, and I would have just probably, yes, ceruloplasmin is, they say, is like just like TB for pediatrician, Wilson is for a hepatologist. It can just present any which way with a family member having a problem, not even you. So that's why we don't discourage anybody from doing that. But doing autoimmune markers, especially sending to any stupid lab which gives you 1 in 40, 1 in 80 titers negative, is a sheer waste of money because they mean nothing for a child of that age. And it was a sheer waste of money.
I can't resist but passing one more remark before we close this case, that this was a completely vaccine preventable case. I mean,
Exactly.
before
Yes, so
universal,
that
before
highlights.
yeah,
Yes,
before
that
universal
highlights.
immunization in Argentina, 46% of the transplants were because of Hep A, especially big Hep B going down. And when they introduced just one dose in the national program, in 3 years, Hep A disappeared as a cause of liver transplant. So I think that's the message, that something which is
ये
vaccine
3 साल
preventable
वाला
must be.
मुझे नहीं मालूम, ये पेपर प्लीज मेरे को फॉरवर्ड करो। ये
मैडम, आप
3 साल वाला तो चल का है, मैं
आपके
कल ही
पास
मिनिस्टर के पास
आप
पहुंच जाऊंगी।
आपको जो कंप्रेस फाइल भेजा है ना बुक का, उसमें है, वो आप पढ़ लीजिए, मैंने ही लिखा
अच्छा,
है वो
बिकॉज
आर्टिकल।
ये था, इट टेक्स सम टाइम, 3 years was like a real magic.
Yeah, yeah,
So,
correct. Okay, go ahead.
one
Should we
more
have we
thing
finished this
which
case?
went
We have
wrong.
another half an hour. Maybe we can take two short cases.
Yeah.
Can I ask one question, sir?
Mohit, yes.
Yes, sir. Is there any
वीडियो
rule of
दिखाओ, वीडियो दिखाओ.
so yeah. Sir,
चूहे तो भी बांधा
is
नहीं,
there
दिखाओ.
is there any role for NAC at this point of a time when the child is in the hepatic encephalopathy with the failure in such a case? And besides that, associated drugs what we have been using,
Mohit,
especially
you studied under me, so you're going to answer this.
Okay,
Because you're
Mohit, you
itching
answer.
to answer.
Mohit,
Usually
would you give
Vishwanath is a little naughty, he
Mohit,
tries to throw
will you
his
yeah.
give
knowledge, but
NS?
I know you're knowledgeable.
Well, will you give NAC, Mohit?
So usually we give NAC in paracetamol definitely, but there are few
Correct.
papers which suggest it can be
I would give it.
in conditions like this. So that's why I
Chalo.
just wanted to. Otherwise, it's not been indicated in such conditions.
Okay, fine. So we go
And
ahead. We are
yeah,
running short of time. Yeah.
done, sir.
So,
Okay.
adding another point of vaccination and what went wrong, the child was not vaccinated for hepatitis A. We should not forget the basics, as we've already been told every time we've been told. So quickly moving on for all of us, what are the three? What is the criteria for pediatric acute liver failure? So
I
acute
think I
onset of,
already said that.
Yeah.
yes, ma'am.
Yeah.
So
She's
again,
just
moving forward.
recapitulating. Yeah. Go ahead. Yeah.
So what are the common etiologies which lead to PALF, pediatric acute liver
You've
failure?
already said that.
And what are the
It depends on the age, and if the
age?
baby comes in the newborn, you think more of galactosemia,
Galactosemia.
tyrosinemia, hemochromatosis. Little later, you think of mitochondrial fatty acidosis and other storage disorders. But in a typical case like yours, number one would be viral Hep A, E, and then sometime even dengue, ischemia, anything hypoperfusion, scrub typhus, anything can give rise to liver failure. Drugs not to be forgotten, Walproate, tuberculosis, and Baba Ramdev GK drugs. which is also to be remembered
Let's
to be
let's say spurious alternative drugs.
spurious alternative
Let's not take names.
drugs.
Yeah, yeah.
Because no, the reason we say in North India is you just have to. I had a child who we ultimately did a transplant and we kept wondering what was going wrong till we did two biopsy and then she confessed that they spent 3 months in Ramdevji's place for diabetic treatment. So that's why in North India we say, Babaji.
Okay. And
That's why.
I will just
He
add last
recently
point.
he
I
recently
just
he
add
made a
last point
comment
that
on
we
air
have
purifier.
And of course, autoimmune liver disease, Wilson's disease should never be forgotten. Like she rightly did, you must do ceruloplasmin and this. And despite all your workup, sadly, 30 to 40% may be cryptogenic. With the availability of newer viruses like adeno, CMV, cryptos, Coxsackie, then you might be able to increase your this thing. But even having said that, even in India we do see cryptogenic, and these cryptogenic are all those ones who seem to be having something underlying genetic, and there's a lot of data about autoimmune also which can present to you like this. And therefore there is a role nowadays of transjugular liver biopsy in the latest guidelines, because some of the series, some of them have talked that you may be able to give them steroids and improve them in those cases.
okay. The last comment is that you also have a Hep E vaccine, okay, from China, which has been marketed in India, but it's only for above 18 and those with already existing liver disorder, so they don't get another Hep E, which precipitates the balance. So while in China is used
Is it
commonly,
available
it is
easily?
available. Very recently, it's been marketed in India. It's known as
It is
Hicolin. Hicolin, yes, Hicolin.
ecoline.
Yes.
अच्छा, तो
All
ये
right.
अच्छा क्यों नहीं करते market? Because I've never seen them come
So
to.
it is because it is a therapeutic sort of only for chronic liver disease. They are not. It's not brought by a vaccine manufacturer. It's brought by a drug manufacturer.
You know why it is like that? Can you guess the answer?
No.
Because
So
I know the answer.
so they might answer to what? What question?
I have the answer to this.
No. What?
So why only chronic
Why
liver
chronic?
disease?
Ah. Okay. That.
Yeah. So even that, what has happened is Hep E, in especially post liver transplant, can conk off the liver. I mean,
Yes.
you end up with a new graft. So it is extremely bad. And probably they eat the raw meat and raw. So Argentina and all, as you rightly said, there were cases where post transplant they did. And that is why I think maybe it is limited for those. But that was a
Correct.
very valid point, Nitinji.
Okay. I think we have time for one case. Shurbi, can we move with maybe Dr. Vishwanathan
Yeah.
again?
Yeah,
One more
please
case.
move
Yeah.
to him. Yeah,
Yeah.
move to him.
Okay.
Leave this
Yeah.
for the experts and say refer to
Yeah.
expert.
Yeah. Yeah.
So
Absolutely.
they'll refer you.
CRRT and all.
So they'll refer
Absolutely.
you.
Yeah, I think in time reference for a transplant to a center where they will decide is, I think, the bottom line for the period. Don't play with the
No, I
patient.
want to say one thing is very clear, and that majority of the time people think that you should refer for transplant, and I would differ. Like in
No,
my
not
place, no, I'll just
no,
complete
not
it.
not for transplant, for further care where it may
Care.
also
You know
involve
why I
transplant.
want
Yeah.
to say is probably the first series which is being published of more than 400 cases, we were able to salvage patients 68% without a transplant from ecology, and for Hepe it was 90. So a
Very
good
good.
treatment, 1:1 care, 1:1 nursing, and a good place can salvage. So don't only refer for this thing. A timely referral is, even if we spend that much money and save that with that, I feel proud and happy that I could save with the native liver.
Okay. Surbi, come. Do you have 20 minutes?
Yes, sir.
Yeah, carry on.
So the last topic for today is upper GI bleed. We all know upper GI bleed can be anywhere from the esophagus to the ligament of treats. 80% of the upper GI, 80% cases have a benign clinical course. And in Indian children, it varies by study. The incidence of upper GI bleed is relatively low, and it is more linked to EHPO, which is the 50 to 90% of the causes. Differential diagnosis is based on age, clinical, and the amount of bleeding, clinical presentation, and the amount of bleeding. So, can melena be a sign of upper GI bleed?
Yes, it is. It is, isn't it? Because the TARI stools basically when it's a small amount of blood going through all the way through GA tract, the color does change, and then it's definitely a sign of upper GA bleed. Hematochezia, if it's a large volume upper GA bleed, if it is transiting through the GA tract in a rapid way, you could have any 10 to 15% of upper GA bleed. You could have hematochezia also. Yeah. Carry on.
Quickly moving on to the case. A 6-year-old boy came with complaint of blood and vomitus a week back, and clots were present as per the parents. He was admitted for the same. One PRC was given. He was referred for further evaluation. He was afebrile, weight of 18 kgs, height 96 centimeters. Liver was 2 centimeters below the costal margin, and left lobe not palpable, spleen wasn't palpable. So past history, had a significant past history of 2 episodes of hematemesis in the last 3 years, and two episodes of PRC transfusion. No workup was done. He was living in a peripheral center. Normal vaginal delivery, birth weight of 2.8, no NICU stay. Immunized as per the national program, developmentally appropriate, similar family history, no jaundice, rash, loss of consciousness, convulsions, sibling death, or recurrent abortion in the mother. So we began with the USG abdomen and Doppler, and large spleen. Was replaced by multiple venous collaterals at porta, suggestive of portal vein carcinoma. There were venous collaterals in the perihepatic, pancreatic parenchyma, spleen, hilum, and in the mesentery. Mesenteric veins suggestive of chronic thrombosis. Hepatic veins were normal. Hepatic arteries normal. Splenic vein. So the HB when he came to us was already post transfusion. He was 11. HB was 5. Platelet was thrombocytopenia was seen 90,000. AST, ALT mildly. AST was mildly deranged. ALT was normal in the normal limit. Bilirubin, total protein, albumin was normal. PTINR was in the normal limit. So what should be the target hemoglobin when we are transfusing such patients?
I think the case, though there was clinically no splenomegaly, I could see an ultrasound there is a splenomegaly. So I think there's a bleed. And here we are talking about most likely an extrahepatic portal venous obstruction. But also we need to know whether there's an underlying chronic disease, because the management, we need to be very careful about that. I think target hemoglobin around 8 to 10 will be okay. In these sort of patients, you don't need to go for higher hemoglobin. And the thing is, as long as, there is no any, we have to make sure there is no any underlying chronic liver disease.
Chronic liver disease. So endoscopic picture, as you see,
Yeah.
4 grade 4 esophageal varices, cases and bands were applied. Workup was sent. He was started at 1 mg per kg. So how do we differentiate between a cirrhotic and a non-cirrhotic portal hypertension, sir?
I think as we discussed, you look for signs of chronic liver disease, also ask for the history. But though there is some history of 2 previous episodes of blood transfusion in the past, whether this could be following a bleed or whether this could be due to something else, we need to know that. But obviously, we need to ask for, history of any jaundice and any signs of decompensations, like, any bleeding tendencies or any sort of, ascites or poor growth. 6 kilo, 6 years old child, around 18 kilo, not bad actually. Reasonably weight is not that bad. And then, in the when you're analyzing, when you're looking at the, for these signs, you look for any sort of, significant distension or dilated veins or palmar erythema. The other things which you see in, adults, we don't see necessarily in children. You look for also the liver span, and then look for any shrunken liver. And then if you're going to look at all those 6, it gives us a clue whether, particularly growth is very important. If the child is malnourished, and if the child, that gives us a clue that something is going on for a longer period of time. That tells you, there is an underlying chronic disease or not. The reason is, when we are having a variceal bleed could be due to an extrahepatic portal venous obstruction, or it could be secondary to portal hypertension due to any underlying chronic liver disease. It's very important for the gastroenterologist to know this one, because when we going and doing this sort of intervention, those who are having underlying chronic liver disease, the risk of bleeding is high, particularly there is hypersplenism, particularly is a low platelet count. That is the reason why it's very important for us to know if there is any underlying chronic liver disease. And very importantly, when you ask an ultrasound scan in your radiologist, always ask them, whenever an ultrasound abdomen is done for a liver disease or ask them to look at the portal vein, look at them, comment on the hepatic vein if possible. That gives us a clue what's going on. So always I tell men, don't have to have an extra charge. They don't have to do a Doppler. They just have to look at the portal vein and the hepatic vein. Yeah, carry on. Thank you.
So these are the few sites of UGI bleed. So the common causes of UGI bleed in different age groups: in neonates, swallowed blood, nasogastric tube injection, stress-related gastritis, cow milk protein allergy, necrotizing enterocolitis, vitamin K deficiency, DIC, or any
One second here. We are talking about upper GI bleed. We don't see that many of upper GI bleed as in protein allergy. They most likely present allergic protocolitis. They usually do not have an upper GI bleed, and usually they are well child, and they may have a history of a lower GI bleed. Particularly, there's a temporal association of having had an introduction of milk, but usually not upper GI. But other things, yes, obviously you need to make sure there is no hemorrhagic disease of newborn. That's okay. That's fine. Always drug in any age group is very important. A significant gastroesophageal reflux disease. I had a 4-year-old girl who had a hemoglobin of around 8, and then the only thing she kept on saying is pain, and she did have a significant erosive esophagitis that can cause and lower upper GI bleed and an anemia. So other things, varicose bleed is what is very important in our country. Could be an extra hepatic portal venous obstruction, or could be an portal hypertension secondary to chronic liver disease. And another thing is non-variceal bleed is not that common, though we could see particularly following drug ingestion, or particularly the peptic ulcer disease in older children, or due to H. pylori gastritis. They're not that common, but we do see them. And I have seen a couple of Mallory West also. But I think most important thing, history of corrosive ingestion is very important. The history of previous surgery, particularly for the fistulas, all tracheoesophageal fistula, atresia, that's very important to know that also. And history of an foreign body ingestion, which they might have forgotten.
So I just to sorry to intervene, but I still remember a case. I mean, many of these cases come to us as chronic iron deficiency. They give iron, they don't improve, or they improve and again fall back, and no one does stool for occult blood for 5 days, and it's strongly positive. You should find out GI bleed, what is the cause. And the child that I was talking about did the upper GI scopy, and he had a grape-like duodenal polyp. He never had upper bleed. He always had only lower bleed and iron deficiency. And this was many years back. And Dr. Yacha had done we didn't have a side view pediatric scope. We defulgurated it piecemeal, and the child is completely okay. So sometimes these rare cases can.
We have a similar case in the presentation of lower GI bleed. If we get an opportunity, we'll present that too.
Sure,
right. Can I make a comment, sir? There's a beautiful slide on common causes of upper GI, and Madam has mentioned about the neonate. And one message I wanted to give: you have to differentiate between the swallowed and the maternal and the baby's blood. Can anyone say what is the test name?
Apt Downey test, sir.
Apt Downey test. It's a very bedside test. Apt Downey test, which will differentiate a swallowed, that is the maternal blood, from the fetal blood.
So the basis behind that is that the fetal blood is all
fetal HB is alkali resistant.
Which resistance. So if it's mother's blood, it will immediately change the color, not the fetal blood. All right.
Very good, important bedside test.
Sir, is the occult blood in infants always pathological?
Mohit, I talked about the occult blood. Yes, occult blood. I do not believe in doing occult blood. For me, if the child's hemoglobin is normal. If the child hemoglobin is low, you evaluate. Because I do not want to spend money on them doing occult blood at all. Because I tell you, because anyhow they need evaluation with GA blood. If we suspect GA bleed, because you have to evaluate. I do not want them to waste money in occult blood at all. Days have gone, decades. It's more than a decade. I have done occult blood. I don't do that anymore. Full stop.
Okay.
Carry on.
So Mohit, it will depend on whom the patient goes to. It goes to a general pediatrician first, or the specialist like Dr. Viswanathan directly. They have a scope in the hand the pediatrician doesn't have. But he finds that the occult blood is consistently negative. He would say that there is no reason to do a GI scopy.
Absolutely.
And he'll find out another cause like malabsorption, celiac, or whatever.
Sir,
Exactly.
we cannot ignore occult blood, especially in the cow milk
No,
No, that's
protein
what also.
allergy.
before you consider G, I'm pretty sure you'll be doing hematological parameters. You'll be checking all those things. You'll be checking all those things. The other
Yes,
thing is left with only GI. If you are ruled out hematological, it's going to be
yes.
GI. So I do not want to do an occult blood in that one. That's the reason I'm trying to say. That's it.
Another common mistake that will happen is that occult blood is negative, you forget about it, but you are not done an X-ray chest and it actually shows pulmonary hemosiderosis as a cause of anemia. So I'm just saying that there could be other reasons besides GI where the patient
Yes.
is
That,
bleeding. All right, go
It,
exactly.
ahead,
it
go
is.
ahead, go ahead, go ahead, go ahead.
This is a beautiful chart of which Dr. Sharish had asked to put with the upper GI bleed, management of upper GI bleed. So when a child comes, you check for the vital signs, CBC, platelet counts, PT, APTT, type and cross-match blood, IV boraxes, NG tube insertion, depends. So if the child is unstable or in shock, you admit to PICU, immediate GI surgical consultation, IV fluids, blood transfusion. In case of a massive upper GI bleed, UGI scopy should be done within 6 to 12 hours. In case of a variceal bleed, we start with octreotides, infusion, antibiotic course, band ligation or sclerotherapy. And if bleeding continues, we evaluate the child for tips. And in a non-variceal bleed, we give a IV proton pump infusion, or we go for endoscopic coagulation and injection of the vessels.
The message to pediatrician in this slide will be when they have a child who is present with upper GI bleed, obviously ABC stabilization, cannula, doing the basic workup, CBC, PT, APTT, and group and cross match. And if they suspect a variceal bleed, they can start very well octreotide infusion. Don't worry about remembering the dose. Always look at the drug formulary. Nothing wrong in that. Give a bolus dose of octreotide, then start a continuous infusion. And then you are very well welcome to start PPI. Do not put a blind NG tube. It's not going to save you much. So I don't think it's needed. So once you stabilize ABC, any cause of upper GI bleed has to be evaluated. So stabilize, refer, full stop. Yeah.
And if the child is hemodynamically stable, we admit in the hospital and GI consultation, start him on fluids. If it's a stable upper GI bleed, we do an endoscopy within 24 hours, start on IV PPI. If it's a variceal bleed, we go ahead with the same management of octreotide, antibiotic, band ligation or sclerotherapy, or tips if required. In a non-variceal bleed, we go for proton pump inhibitors or endoscopic coagulation if required.
What I'm
This
saying is for the pediatrician, when they're having a case of upper GI bleed, even if it is very shallow, there is nothing wrong in starting a PPI when they are referring. That's absolutely fine. Yeah.
Yes.
And there's no need to start antibiotic unless absolutely needed.
Yes.
Thank you.
So this is a few drug formulations available in the market: ranitidine, sucralfate, lansoprazole, pantoprazole, and octreotide, which can be used. So we all know PPI are better than ranitidine. Sucralfate, the role of sucralfate in children below 12 years of age is still debatable. And octreotide, we start at 1 microgram per kg bolus followed by 1 microgram per kg per hour infusion, which could be increased to maximum of 5 microgram per kg per hour. And dose of lansoprazole below 30 kg is 15 mg per day, more than 30 is 30 mg per day. Pantop, we begin with 2 mg per kg, maximum of 8 mg loading, infusion of 2.2 mg per kg per hour, maximum 8 mg per hour.
And in infants, rather than starting PPI, I would rather suggest to start ranitidine in infants, particularly, unless there is anything severe, you suspect severe bleed. Okay, carry on.
Recently, ranitidine has been approved by the FDA.
Yeah, no, yes,
Yes,
that's fine, sir. That's only 1 or 2 companies which are their issue. It's fine, sir. It's back in the market. Yeah.
It is approved. It is approved.
Last
Yes,
one.
yes.
So what the key messages are: early resuscitation, high dose of PPI therapy for at least 72 hours, urgent endoscopy for a severe upper GI bleeding, and a combination therapy is preferred over only medical management.
And I want to just tell the pediatricians here, we do have now and then non-variceal bleeds, like drug-induced, or it could be I had a child who has got a duodenal what do you call it, dilophoid lesion, and which were able to sort it out with clips. And we had children who has had bleed, which were unable to find the cause at the upper GI, lower GI. When you did video capsule endoscopy, we were able to spot, as Dr. Nitin mentioned, we were able to spot a problem in the jejunum, which is basically an bleed following a polyp bleed, and then which we were able to do an endoscopic intervention. So what you're trying to say is upper GI, lower GI, if you're not unable to find a cause, they will need a video capsule endoscopy plus or minus enteroscopy and intervention. The tools available for us: clip, for non-variceal bleed, and also we can use APC, organ plasma coagulation, and also we can use hemospray, which is not very much available everywhere, which is a bit expensive. Carry on.
So before, I think we have finished the case, Surbhi?
Yes, sir.
Yeah.
Yes.
So before we conclude today, I cannot resist but to ask Dr. Vishwanathan, forget the GI bleed. Common reason for admitted patient put on PPI, IV pantoprazole. So every child with fever, little vomiting. It can be damaging, like it can mask infections. I mean, your point, your
Well, I think
point.
you actually you had asked a very valid question. As you rightly mentioned, I don't think any reason for starting PPI just like that for any child presenting with pain. The common reason for pain for me today and then last day or a week, a month ago, and it's going to be another 1 year. It's going to be constipation and significant infection, and there is no role for PPI in that. And the next 10 years, 1 year, that's the most common reason for the constant pain. If you suspect acute pancreatitis or if you suspect acute gastritis, then there is a role for starting PPI or any sort of bleed. Otherwise, I do not think just like that. A simple paracetamol will be enough most of the time.
Yes.
As a gastroenterologist, I hardly have to use NSAIDs. I do not have to use paracetamol, does wonders for me. If at all I have to use something else more than that, I go for tramadol. Also, tramadol with paracetamol combination is available for me.
Yes. In fact, one of my student is doing thesis right now on single or few doses of NSAIDs and how much is the urine beta microglobulinuria happens. And then these are subtle renal damages of interstitial nephritis. If the child goes into high creatinine and sick, then at least he will be saved because you won't use it again. But the ones who have asymptomatic microglobulinuria, you keep on giving ibuprofen or mefenamic acid for every fever, cumulative damage, and they become young patients with renal failure, which is iatrogenic and actually without any reason. So surprising that 20% of children who have received NSAIDs while in the hospital or on the OPD basis have beta 2 microglobulinemia, which is significantly high. And we tell them that please do not use NSAIDs in future unless you are really forced. And these are eye opener. I mean, one of our nephrologist friend who is at Hinduja Pediatric, he believes that all these 20, 30 years young people who go into renal failure without any reason with small kidney to start with are probably the pediatric gift of misuse of NSAIDs. So very well said that NSAIDs should be used very sparingly. In fact, if you see now orthopedic people, their preference is for a sustained release paracetamol for pain and tackle the cause of pain like exercise, tending muscle, tendon, etc., rather than keep on taking NSAIDs days and weeks and months together.
I hope Nimusuline is not available in western part of India. I hope.
Syrups are bland now. Drugs are available, tablets are, syrups are
I
bland.
will just make sure that they don't use
So
this
we,
Nimusuline at all. Thank
we
you.
used to say that nice tablets are really not that nice.
Yeah.
Yes, Dr. Jalil, any last comment before we wind up today's session?
I'm audible, sir.
Yeah, you are.
Sir, I'm
Though you
sorry,
are oblique to
sir.
us, you are not straight.
Sir, both the session by Madam and my friend MSV is excellent. I have been a constant observer for the Gujarat messages, sir. This one question to MSV. Since the mantra from MSB is stabilize and refer, stabilize and refer. In a research limited setting, especially with the foreign body, be it a button battery or sharp or whatever it is, till the baby reaches the urban area, what is your first measures can be done by the referring general pediatrician or general physician?
Foreign body, you're saying, huh? GI
Yeah.
foreign body.
Yeah.
Yes.
Okay.
It depends upon the foreign body. If it is a button battery, sharp foreign body, or if it's something in the esophagus, just refer, don't do anything. Put an IV cannula, keep the child nil by mouth and refer. And keep the child nil by mouth, put some IV fluids, make sure the blood sugar is fine. If there's any issues about airway, stabilize the airway and send it. If it is something else, you do whatever you want to do, but at least give a call to the friend, pediatric gastroenterologist, whomever you know. At least they can guide you whether the child has to be referred right then or whether you can keep the child there. That's absolutely fine. So at least you can call if you're unable to refer. But that's because we are in the world, it's a vast WhatsApp world. It's very easy to reach out to people, and you can also take, the parents, you can take a photo. I mean, the parents usually, if you ask them now what sort of things they have given at home, they may not have brought up the corrosives, for example, but they would have taken a photo of that. Or if you can just show on the internet, they will match it for you. There are so many ways we can do that. So If it is in the esophagus, you refer, otherwise you will be in trouble. I can assure you on that one. If it is somewhere else and if it's not child is stable, you call and then you get an opinion and act accordingly.
As
So
a as a
what
part
is
of
the role of
first,
honey in button battery in such cases, sir? Whether it is in
We
esophagus?
discussed
yes,
that,
yes,
Mohit.
Honey,
yes,
I
yes.
spoken to you, joined late. I spoken about honey, I
Yeah,
spoken
it
about
has been
Okay,
sucralfate.
mentioned.
I will
done,
give
done.
you honey,
Sorry,
don't worry.
No,
don't worry.
no honey, no banana, no milk in a
No, 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 no,
curry.
no, Listen,
Sort
listen.
of.
No,
No, no, no. Honey has to be given except
we
under
told,
1 year.
we
Button
told,
battery, that's the only thing that we
Yeah.
need to
you
give.
can give it,
The
but
honey
before
is
you
the
give,
part of the
Listen to
treatment.
him, Jalil. Listen to Dr. MS.
listen, you can give honey, you can give sucralfate more than 1 year, but the first thing you do is start the referral process.
Correct, exactly.
And then you give it because you should not delay the referral process. That's the important point we are trying to make, because some of my gastroenterologist colleagues are not happy to talk about honey at all. I told that we have to say something to the pediatrician, let them do something. But if the child is unstable, the child is having issues about airway, the child is, you are
Yes,
suspecting bleeding or suspecting complication, don't give honey. Full
correct.
stop. Don't give anything by orally. You are refer.
Perfect.
And I
Otherwise, you
pres
are fine. You are welcome to do that within 12 hours. You can
Honey
do
is
it.
only for button battery and not for anything.
Correct,
yes,
correct.
yes, yes.
Neelam, right? Button battery only and nothing else.
Only for button. I made a beautiful video. I'll send again. It was
Super.
Okay, I think
created by the World
we are
Congress.
running short of time. Sorry, we are running
One
short of time.
final comment about
Jalil,
that
we are
chart.
running short of
One
time. Maybe
final comment.
you can speak to MSV on his personal
Yes,
chat.
Yeah,
I'm
yeah.
really
yes.
sorry. It's almost
The role of
10:30.
charcoal.
I wanted to just say
Okay.
good night to
But
everybody and
I
thank
have to
you for
fly tomorrow morning, so also Dr. Neelam has to fly if she's not already reached Guj Pedicon, and I'm sure Surabhi is now catching a train to go to
Before I
Rajkot.
forget, Nathan,
Yes, MS.
before I forget, I want to really thank Surabhi for making this so many slides for three
Absolutely,
of us, and that is not
absolutely.
easy. And thank you so
Yes,
much. Thank
yes.
you.
I mean, she's brilliant. I knew her,
Excellent.
that's why I chose very carefully. As Jalil said, when we do Gujarat Pediatrician WhatsApp group, we are very, very particular about who comes on the field. So thank you,
Excellent.
Dr. MS,
Excellent.
Dr. Nilam, in spite of a busy schedule, both as the president coming, your 650 workshop that you have planned, and flying tomorrow to Gujarat,
it.
and
Crossed
I'll meet you there.
700 now.
700. And so, in spite of that, you joined late night. And of course, everyone else has said, Surbi, you did a wonderful job.
Yes,
I
sir.
mean,
Bless you.
absolutely pit pad. And I think we have a very, very strong future GI expert as a speaker. I'm sure every GI expert is an expert, but as a speaker to deliver. Very happy with you. Thank you, Dr. Ramesh Bhai. Are you still there?
Ramesh ji, Dr. Ramesh.
I think he's at the Gujarat Pedicon, so probably he has a little poor connection.
Oh,
Okay, we'll wind up tech. You can stop the recording now. And everyone, good night. And it was a wonderful learning from
Good
the
night, sir.
seniors and maestros. And we will again join back next month with one more interesting case in some other series. Thank you. Good night. Shabak hai.
Good night. Good night.
Thank
Good
you,
night.
Dr. Nitin ji, and all people. Thank you very much.
Good
Thank you.
night.